Mhm. Thank you, everyone, for joining us today. I am honored to introduce today's speaker, Professor Michael Vortmann. Michael Vortmann chose to practice emergency medicine because of multiple childhood accidents and watched the 90s television drama series ER. He has worked in affluent and underserved communities in the West and East Coast of the United States and participated in clinical service and global health research projects in India, South Sudan, Haiti, Qatar, and the UAE. He previously taught wilderness medicine at Cornell University and ran medical student electives in New York City, the Adirondacks Mountains in New York, Costa Rica, and the American Southwest. Dr. Vortmann currently practices clinical emergency medicine in the Boston area as an affiliate clinical faculty at Tufts University School of Medicine. Thank you, everyone, and I'd like to present our faculty today, Michael Vortmann.
Hi, good morning. Good morning, good evening, good afternoon. Thank you, Shawnee, for that lovely introduction. Let me share my screen here. Can everyone see this appropriately?
Yep, it looks like we can see your screen.
All right. So when I was asked to do this, I know that you all are coming from different backgrounds in terms of your training and knowledge. And I'm an emergency medicine physician, which even in the West is a relatively new specialty. It's one of the youngest medical specialties, and it's still kind of in its nascence in many parts of the world. And so I wanted to talk a little bit about both kind of how doctors and emergency medicine people think. I wanted to kind of talk about how we approach sort of an undifferentiated sick patient. And so kind of give you some insight if you come across a situation where there's someone who's sick, that you have a little bit of information to know what to do. And then I wanted to talk about major killers throughout the world, which, as the world becomes more affluent, are becoming more and more similar. And the kinds of things we do both in more resource limited settings and kind of in hospitals, and sort of what medicine in general can provide. So hopefully at very least I can demystify some of these situations where, it can be very confusing and complicated. And so I hope you guys learned something from this. I'm going to try not to use medical jargon as much as possible, but please, if there's a clarification, please ask it. And then I also tried to not include videos just because I'm sensitive to bandwidth issues. And so sometimes that can cause the presentation to hang. So that's why I don't have any videos in this. But so, Shawnee kind of talked about why I chose to do emergency medicine, which was this 90s show ER, which I think you can probably find on YouTube. But basically it took place in a large public hospital in Chicago. And, these people came in and they were kind of undifferentiated ill people. It was always chaotic. And these very cool doctors kind of would bring order to chaos and sort of figure out the problem and solve it. And I thought that, hey, this is the kind of adult I would like to be when I grow up. And turns out now that, 25, 30 years later, that I actually know medicine, the show is not inaccurate. People are a little more attractive than they are in real life, and the lighting's very good, but it's pretty spot on. There's another program you may all have seen or heard about. It's based on a book called Call the Midwife, and the BBC has a program, and it's about nurse midwives who kind of go around the East End of London in the 1950s after the National Health Service is invented. And they go around delivering babies in a poor part of London. But the part of it that interests me is that whenever anyone's really sick and the nurse midwives can't handle it, they have to go find a phone, which isn't easy to find. They have to call the doctor, who has to call the ambulance, who then brings the patient to the hospital, and maybe the surgeon or the specialist is on call, maybe they're not. And so there's a lot of delay where bad things happen because they have this system that just doesn't recognize that sometimes things needs to happen quickly. Now, there was a recognition of this in both the United States and the UK, starting in the 1960s. And there were a bunch of papers that were written kind of looking specifically with accidents, road traffic accidents, that a lot of delay in care led to people dying or having severe injury that couldn't be fixed afterwards. And so in the United States, in particular, in the 1970s, they started to standardize ambulance services. They came up with training programs to standardize the care for injured patients or patients who were in cardiac arrest whose hearts had stopped. And the idea was to improve care, make it timely, and make it sort of up to whatever science was available. So in 1979, emergency medicine was founded as a specialty in the United States. So it's basically, 45, almost 50 years old. So relatively young in the sense of kind of medical specialties. So perhaps the most succinct way to say what emergency medicine does is that it does not manage a specific disease, but the time-dependent exploration of an intervention in the acute physical and/or physiological crises of humans. So basically, what I do and what emergency medicine does is we see people completely undifferentiated, and we try to figure out what problems they may have, but also to do the testing and do the interventions that need to happen in a timely fashion to prevent further injury or illness from occurring. So when we talk about what people die from around the world, this is a slide from the WHO, and it kind of gives a sense of causes of death by region. And this is Southeast Asia, which is kind of emblematic. And in the color coding, you can see that the green bars are communicable diseases, which are things like infections in particular. And then the blue are non-communicable diseases, which are diseases of chronic illness, things like high blood pressure, diabetes, stroke, heart attack. And you can see that in the last 20 years, there's been this marked shift where it used to be that communicable diseases were the leading causes of death, and non-communicable diseases now are the leading causes of death. And this is not necessarily a bad thing, because it means that the world is living to be older. It means that people aren't dying of infectious diarrhea or pneumonias as they used to in the past. But it also means that some of the care that's provided or needs to be provided is a little more complicated. So this kind of pattern you see throughout the world. The one exception is Africa, but even in the two leading causes of death are ischemic heart disease is the number one, so things like heart attacks, and the number two is stroke. So this is sort of a marked shift from what it's been. And even in Africa, which is still a region where communicable diseases, particularly neonatal illnesses and injuries in the first year of life, and then also in respiratory infections, so like pneumonia, are the leading causes of death, you can see that those two blue bars that were at the bottom have sort of like jumped markedly in the order of things that harm people. So even in Africa, you can see that these non-communicable diseases are becoming increasingly a problem. So when we talk about the time course in which people die, there's this concept that was first introduced in trauma that's actually very interesting. It's called the trimodal distribution of death. And what happens is that when someone is injured, some things people die from right away within seconds to minutes of the injury. And then some people die later of things like, overwhelming infection or organ failure. But there's a so-called golden hour that occurs kind of within the first few minutes to few hours of someone's injury, where you can provide a lot of intervention that can reduce people from dying and having severe subsequent illness and injury. And this is an important concept because, and it can be expanded to other areas of medicine where sort of the timely provision of care, it's actually important, and that if you provide that very same care later, you don't get the same effect, and people end up harmed because of that. So moving on, we talk about the ABCs of emergency care. Now, we talk about ABCs partly because it's the alphabet, but also that they're like doctors love mnemonics and we love heuristics, and these are kind of two ways that doctors think. Mnemonics are kind of memory tools that kind of help you remember something. And you can imagine when someone's very sick, it can be very stressful and you're trying to remember, oh my gosh, what do I do? The ABCs are something that pretty much all doctors know, that kind of is a mantra to go through in your mind, what might the problem be? And the ABC stands for airway, breathing, circulation, disability, and exposure. And I'll talk about each of these in more detail. So even before we get to the ABCs, though, there's something I want to bring up, which is scene safety. And a lot of times when something happens, whether it's an injury or a heart attack or someone's heart stopping, it'll occur in a situation that may or may not be safe. And this is a picture of the collapse of the Rana Plaza in Bangladesh in 2013. There was this factory that kind of suddenly collapsed with many people inside. The question that I would ask of you sort of rhetorically is, well, what's the problem with this picture? Like, what do you see that could potentially be an issue? And I would say look, if this building collapsed, there's hundreds of people gathered around. Is this actually safe? Like, what if this building further collapsed? Are we going to create more injured patients, more problems by not having this scene a little more controlled? And so it's important when you're trying to help someone in a situation like this to think about, okay, is this safe for me to provide care or assistance, or do I need to leave, or do I need to bring this person with me? And so you want to always think about context before you sort of get into the situation of helping the patient. The other thing that this brings up is that you really do want to call for help if there's a situation where someone is injured. One of the first things you want to do is ask to see if someone can either activate the emergency system or call an ambulance or get someone who knows the person. So moving on, we talk about the ABCs. So the first A in ABC is airway. So one quick way to kind of assess all of these things, it sounds very complicated. It's not necessarily. One of the easiest things to do is to just ask a question and introduce yourself and ask if you're okay and what happened. So if the person is able to tell you and sort of explain what happened, A, they have enough airway so that they can breathe and make speech. B, they have that their voice is working. C, they have enough blood supplied to their body, to their brain to kind of permit speech, but also to think about the problem. And D, their disability refers to kind of brain function, that is generally okay. So in that situation, even just asking that simple question can establish that all of these things are all right. And then if they're not, then you kind of can go through this mnemonic and this algorithm and figure out further what might be the problem. So when we talk about airway, like what does airway exactly mean? Airway is sort of from the passageway that goes between the mouth and the nose into the lungs. So it's a complex structure. It's made of soft tissues that aren't rigid. And you can see it has multiple axes in the upper right-hand corner that involve the mouth, the back of the throat, the voice box, the lungs, the airway, and then the trachea, and then the lungs. If someone's not breathing properly or seems to be having a problem breathing, one easy thing you can do is put them in what's called the recovery position, which you can see in the picture at the bottom. And basically you roll the person onto their side, you put the arm and the leg out to keep them from falling flat onto their face. And this does two things. One, it keeps the tongue from falling back on the back of the throat, which often blocks it. And if the person vomits, which sometimes happens, you can, the vomit will just kind of drain out of the side and they won't breathe it into their lungs, which can be its own problem. More advanced things you can do that aren't difficult. The one that you see in the top is called the head tilt chin lift. So basically you tip the patient's forehead backwards and you try to lift the chin. And what this does is it kind of opens up the airway, and in particular can pull the tongue off of the back of it so that it's not blocking it. Another technique that you can do is the one you see in the bottom picture. It's called the jaw thrust. And if you kind of do it with me, find the back of your ears and the back of your jaw and you find the angle of your jaw, which is that part where it starts to come forward, and push it forward so that your lower jaw comes forward. If you do that, you'll notice that it's actually quite painful if you do it. This has the technique of doing this will also lift the tongue off the back of the throat, but it's also a little stimulating. It's painful, and sometimes when someone's unconscious, stimulating them a little bit can get them to breathe. It's also good if you think someone has a neck injury, because you can do this maneuver without moving someone's neck too much. So if someone has an injury, that this is kind of the preferred way to open their airway. In a more advanced setting, so something you might see a paramedic do, or in a hospital setting, is we'll put in an artificial airway. And what this is it's a tube, a flexible tube that you insert using a curved blade called a laryngoscope that has a light at the end of it. And you stick it into the person's mouth and lift the tongue off the back of the throat, and you basically put it through the vocal cords. And this is one way to kind of bypass all of those soft structures that tend to collapse when someone is unconscious or impaired, and provides a direct passageway of air into the lungs. So moving on to breathing, sometimes it's obvious when someone's breathing. You can see their chest rise, they're talking, but sometimes it's not. And in the picture, you can see a good technique is how you would assess breathing if it's not entirely clear that the person is breathing. It's called look, listen, and feel. So you kind of want to get your face close to the patient so you could feel the breath on your cheek. You can hear the air going in and out, and then from that angle, it's easier to see whether the chest is moving up and down as it should. If the patient's not breathing, then you can provide something called rescue breaths. And again, there are many courses to sort of explain CPR and kind of advanced cardiac life support. I'm really just trying to give you some information and demystify the whole thing if this is something you haven't been exposed to in the past. So we talked about the chin lift before as a way to open the person's airway. And so what you do is you pinch the person's nose shut, you tilt the head and lift the chin, and then you put your mouth over their mouth and breathe in over 1 to 2 seconds. You provide a breath every 5 to 6 seconds. So it's about, 10 breaths a minute. And you have to let them exhale. And that will happen passively because the chest will basically recoil and, pull the rib shut and cause the air to come out. Now, this is a little complicated, and sometimes people are squeamish about providing rescue breaths, but we'll see later, even if you don't feel like doing this part of it, it doesn't mean that you can't help. There are other things you can do. Now, the one exception to that is in children. Most children who have a heart problem where their heart stops or they're not circulating blood is caused by underlying breathing issues. And so providing rescue breaths to unconscious children is something you probably should do. In adults, maybe it's not as helpful, and you can decide. Moving on to circulation. Circulation refers to both kind of whether the person has a pulse, but also are they, what does their color look like? Does there seem to be blood going to the rest of their body? And you could tell that basically based on a person's color, like are their lips blue? Do they look pale? Do they look gray? When you're feeling for a pulse, there are 2 places that are the easiest to find it, and they're often exposed in people. One is the carotid pulse, which is a large artery. If you find your voice box where you speak, and you go either to the left or to the right with 2 fingers, you should be able to feel a pulse. You can also feel the radial pulse, which is the one on the wrist just next to where the thumb is. Again, use your 2 fingers, not your thumb, because your thumb will have its own pulse. When you're doing this, it really shouldn't take any longer than 10 seconds. If the person is unconscious and looks bad and you can't seem to feel a pulse, you should move on to the next thing because they probably don't have one. So if the person doesn't have a pulse and they don't look well, they have kind of an unnatural color, then we can provide chest compressions. Now, these 2 pictures kind of demonstrate how you should find the location on the chest. It's really just kind of in the middle of the chest, halfway between the collarbone and the bottom of the ribs, or to 2/3 of the way. When you're doing chest compressions, you take both hands on top of each other, and you can either put them on top or interlace your fingers. And when you're pushing down, you want to lock your arms and bend at the waist, because your arms aren't going to have enough strength to actually to compress someone's chest. Now, this kind of, a lot of you may be like, oh, well, I wouldn't want to sort of do chest compressions on someone who was alive. And this kind of gets into this idea of risk versus benefit in medicine. And that, every 1 minute delay if someone's heart is stopped is a 10% increase in their risk of dying. So after 10 minutes, pretty much everyone whose heart stopped who hasn't been resuscitated is dead. And so it's like, well, what if I do this and the person is alive? Worst case scenario, they wake up and say, ow, get off me. Maybe you break some ribs. But best case scenario, you may save their life. So this is a situation where it's really kind of the risk seems relatively minimal compared to the benefit that they might receive. Some of you may ask, well, what is actually going on when you do chest compressions? And remember that the heart is a pump, and you're trying to kind of mimic that pumping function by externally compressing it. So when you compress the heart, blood flows out of it to the rest of the body, and your brain and your other critical organs are getting blood. But the part when you release the chest and it recoils is as important, because that's when the heart refills with blood, but it's also when the heart itself gets circulation. And so the kind of compression, but also relieving the compression and the decompression part of it are equally important. As far as how quick do you do it and how deep do you do it, they've actually done some interesting studies where they found that 5 centimeters is about the ideal depth, and 100 to 120 compressions a minute is the right speed. And for those of you, your favorite pop song usually has a beat of about 100 beats per minute. So it's about that fast. But if you think of a song that you like that's popular music, that's going to be about the right tempo to do it in a timely fashion. The other thing that you can see that's interesting is on the y-axis on both of these graphs, you look at the probability of survival to hospital discharge, which is how they assess the effectiveness of these interventions. And it's actually quite low. It's 5-6%. And these are slightly older data, maybe 5 years old. But it points out that in media settings, you have this impression that people are always surviving from cardiac arrest. In reality, that's not necessarily true, although there is a percentage of people who can survive if you provide adequate and timely care. So I mentioned before that, if you didn't feel good about doing rescue breathing, you didn't have to. And this is a graph that kind of shows you, why that is. And so on the top graph, the A graph, when we provide CPR with rescue breaths, we find that, you do the compressions when you stop it to provide the rescue breaths, because you have to stop it to get the air in, that the pressure of the blood in the body drops to almost nothing. But when you start the compressions again, it doesn't automatically go up to what it was before you stopped. It takes a couple rounds of the compressions to kind of prime the pump and get that pressure to a higher level. And there's a trade-off with that, because you want to maybe provide the person with air exchange, but at the same time, every time you stop, the actual circulation is diminishing. In the B graph, this is what happens when you do compressions without stopping, and you have a fairly continuous amount of pressure that's generated. But again, you're not providing gas exchange. So there's a little bit of a trade-off between those two. So the point is that, if you have 2 people and you feel comfortable doing CPR with breathing, do it. If you don't, then you can just do the chest compressions, which honestly are far easier to do correctly. Some of you may have seen these things called AEDs, which stands for automatic external defibrillator. And you'll find them in a lot of public places in the West now. Over the last 20 years, they've become very common. You'll see them in airports, in international airports, and train stations. They usually have a heart with a bolt through it as the universal symbol, but the color is sometimes green, it's sometimes red, and it's sometimes like a yellow. When a lot of times when someone's heart stops, the underlying problem is that the heart is an electrical organ, and it's not kind of beating in an organized fashion. And what you kind of have to do, to use a computer metaphor, is to sort of reboot the system and hope that it restarts properly. And so if someone collapses in one of these settings and you think there might be an AED, it can be very helpful to have someone go get one. The AEDs will actually tell you what to do. But basically it'll say, you know, do CPR, stop CPR, put these pads on the patient in these defined areas, and then it will have you stop CPR while it analyzes the person's heart rhythm. If it thinks that a shock is advised, it'll have you stand back and it'll deliver an electrical shock to the person, which is essentially kind of a reboot of the heart's electrical system in the hopes that it will restart again. Access to rapid defibrillation, which is what this is called, is one of the key things when someone's heart has stopped from a rhythm problem that affects improvement in death rates or improvement in mortality. So if this is something accessible where you happen to be in a place where there is one, look for it and get someone to go get it or go get it yourself. Another component of circulation is bleeding and stopping bleeding. And I'm mixing a bit, kind of, for those of you who are in medicine, medical and surgical or traumatic causes of injury. But when you have someone who's bleeding, there are a couple steps to get the bleeding to stop, because stopping the bleeding is something that you need to do as quickly as possible. First thing is to apply pressure with your hands. It will usually hurt if you're doing this properly, but that's okay. The most important thing is to get the bleeding to stop. If that doesn't work, you can put a dressing in the wound itself and then again apply pressure. And if that doesn't work, you can apply a tourniquet. Now, a tourniquet is a band that basically goes around a limb and tightens it enough that it stops the blood flow. This is painful, but again, you're trying to stop bleeding, which is going to cause downstream problems, and it's only a temporary fix. Tourniquets, you can use your belt if you have one. That's a good tourniquet. You may have to put a hole in it to sort of cinch it tight enough to stop the bleeding, but you can also make them, and this is easily kind of Googleable on or you can look it up on YouTube. But basically, you can take any sort of band, you tie a square knot with some hard stick or maybe a butter knife in there. You secure it by tying it, and then you twist it until it stops the blood flow. And again, this is going to be very painful, but it is, you know, if someone has a very deep wound on an extremity, it seems to be bleeding heavily, this is something that can save their life. And applying it later does not have the same beneficial effect because the blood is already gone. I kind of want to get back to this, this kind of trimodal distribution of death that we talked about with trauma, and this idea of the lethal triad, which is, you know, when people are bleeding, they have this lethal triad of coagulopathy, which means that their blood doesn't clot because they consume all the different factors that make the blood clot, which we'll talk about a little later. Their blood gets acidic because it is not able to clear all of those products of metabolism that are just a necessary part of life. And they tend to get cold. So hypothermia means cold. And when someone is bleeding, if you don't stop the bleeding, all of these things kind of build up and it causes downstream problems, such that even if you go to hospital and the patient gets given blood back to them, it's not the same as stopping the bleeding in the first place. D stands for disability, which it refers to kind of general functioning of the brain and neurologic system. And this is a little more complicated. I just wanted to point out that this is part of the mnemonic, or part of the kind of way that we think about how someone might be injured or in a serious manner. It basically looks at sort of how someone is, whether their eyes are open, whether they're able to speak, whether their speech makes sense, and whether they're able to move, and what their movement looks like. There are scoring systems we use to kind of quantify this and give it a number, and that kind of will let us know how severely injured someone might be. So the Glasgow Coma Scale is the most commonly used one. The other thing that you can indicate that someone's severely injured is to look at their pupils. Pupils should react to light, and they should look the same. In particular, if someone seems unconscious and they have a very big pupil, that's a sign that they have a severe injury of the brain. And the reason for that is that when someone has bleeding in the brain, you can see in this picture, it applies pressure on the brain that compresses some of these nerves that are at the base of the brain that supply the eye. And that compression kind of will cause a dysfunction that makes the pupil dilate. So that's just some interesting information for you. That I think you, that I thought you might want to know. And the last part of the ABCs is E, exposure. Now, as I pointed out earlier, when people have bleeding or when they're injured or when they have a cardiac arrest, they tend to get cold because they're lying on the ground. Now, again, these ABCs were developed mostly in temperate climates where people tend to get cold because it's cold outside. It's equally possible that someone can be too hot, right? So if someone's in the tropics in the sun and they're lying on the ground, that's someone who maybe needs to be kept cooler, right? Because being too hot or too cold, they can both have their problems. So that's sort of the end of the ABC, the ABC part of it. And I wanted to kind of move on to the bit where we talk about causes of death. And I sort of talk a little bit about both heart disease and stroke, and the kind of how to recognize it, what the underlying problem is, and the kinds of things that we do in hospital settings, and how you can kind of recognize that and get the person the care that they need in a timely fashion. So first of all, let's talk about ischemic heart disease. And what is ischemic heart disease? And what is a heart, which is basically a heart attack? And one question is, what does a heart attack look like? What does it feel like? And this gentleman in the picture on the right is kind of what oftentimes people with a heart attack look like. They have chest pressure. Sometimes they feel giddy or dizzy. They have shortness of breath. They may sweat. They may have nausea. The key thing about it is that it's worse with exertion. So anything that makes your heart work harder, whether it's walking, whether it's emotional distress, these are things that will make that symptom, whatever it is, worse. And so it's important to recognize that, and that in particular in very, very old people, so people maybe in their 80s or in women, that sometimes the symptoms are subtle and sometimes they're not classic chest pain. Now, in terms of when you look at the structure of the heart, what is actually going on? So remember that the heart is a very active tissue. It's always working, it's always beating. And so it needs a constant supply of blood to both bring in oxygen and nutrients and take away waste products. It's also an electrical organ, and the way that it generates its electricity is it has these pumps that move potassium and sodium in and out of the cells and then cause calcium to be kind of sequestered and then released within the muscle cell itself. So there's all of these ions that are moving back and forth constantly that generate an electrical potential and then subsequently cause the muscle to contract. So in the kind of middle picture, you can see when someone gets a plaque, which is basically sort of a narrowing of the arteries of the heart, it can get progressively narrow and then a clot can form. When that clot forms, no blood flows through, and all of that electrical potential, which it basically gets disrupted. The heart muscle can then get starved for oxygen and waste products build up, and that can manifest as electrical problems, which require defibrillation, like we saw in an earlier slide. What causes these plaques to form? Well, the things that are also very common throughout the world as we all become more affluent. High blood pressure, diabetes, high cholesterol, smoking, and family history are the major 5 cardiac risk factors. And what happens when you're exposed to these risk factors over time is that you get these fatty buildups in the walls of the arteries all over your body. And that itself can narrow the blood vessel, but then the wall of the artery can kind of thin, that plaque can rupture or kind of break into the center of the artery where the blood is flowing, and will generate a clot to form. When that clot forms, that's when you get a heart attack. Now, this occurs all over the body. As we'll see later, it's also kind of the underlying mechanism of how strokes, most common kinds of strokes, occur. In the heart and in the brain, it causes the most problems. You can have the same thing happen in your kidney, but it's generally not going to kill you in the way that a heart attack or a stroke might. So how do we tell someone's having a heart attack when they come to a hospital? Now, this is not something you can do by yourself, but I kind of want to demystify that process when you come into a hospital setting. So how do we know how severe a heart attack is? So there are different kinds of heart attacks. Sometimes that artery is completely blocked off and you don't get any blood at all, and that's the most severe kind. Sometimes it's just partly blocked. And we can see that by looking at the EKG and looking at the pattern of the electrical discharges in the heart. The picture in the lower right shows what an EKG is actually looking at. And what it is vectors of the heart taken from different axes that kind of give you an overall picture of what's going on. So, one plane is basically cutting the person from front to back. If you section the heart like that, the other one is sort of is in this kind of a plane, sort of like this way. And looking at the pattern of the vectors, you can actually even tell what artery might be affected. And depending on the artery, kind of affects how severe the heart attack might be. When we talk about what's going on with heart attacks and strokes too, I mentioned the clot, like a clot forms. And it's like, well, what is a clot exactly? So clot is made up of 3 different things. It's made up of fibrin, platelets, and red blood cells. Now, red blood cells, you probably understand what that means. These are these disc-shaped cells that circulate in your blood and they carry oxygen. They are the biggest components of this. Platelets are these much smaller things that look like raisins, and they get activated. You can see a picture of the non-activated platelets in the black in the electron microscope, and then they're kind of smooth all around. When they get activated, they have these spikes that go out and they get very sticky. And those cause the platelets to kind of stick to both red blood cells and to fibrin. Fibrin is a protein that normally is circulating in the blood inactive. And you can see in this, this picture on the upper left that there's something called the clotting cascade, which is a series of proteins that are inactive. They get activated, and that generates fibrin, which is sort of like this sticky thread that holds everything together. So the fibrin sticky thread, the platelets, which are like little raisins that are sticky, and the red blood cells, which are kind of like bricks, all kind of clump together and form a blood clot. So the reason that this is important is that there are all these different targets to kind of break up blood clots or make blood clots less likely to form. You can see, some of you might ask, like, well, what's the point of this complicated cascade of proteins that clot? And the answer that we think is that, having that many different inputs allows it to be a very tightly balanced system where it's constantly being activated and deactivated. And that allows it to be very subtle. And, the ability to form clots and stop bleeding is essential to life. But in the cases of heart attacks and strokes, it is a mechanism that, maybe in most cases beneficial. In this particular case, it's not beneficial, and we need to kind of manage it to help the person get better. So interestingly, a very easy, cheap intervention that's available the world over is aspirin. And what aspirin does is it inactivates these platelets. It keeps them from turning from these smooth-sided raisins to these very sticky ones. And when you do that, you make blood clots both less likely to form and more likely to break up if they have formed. The dosage is 325 milligrams, which is basically 1 adult aspirin or 4 baby aspirin. And doing this actually has a huge impact on death rates. It actually reduces mortality by 50%, which is huge. So if you're in a situation where you think someone may be having a heart attack and you're going to take them to hospital, give them and have them chew a full dose aspirin. If you have older people in your household, it's a good idea to have some aspirin on hand in case this becomes a problem, especially if your older loved one has diabetes, high blood pressure, high cholesterol, or they smoke. Because as we talked about, those are the risk factors and those are the things that are going to cause this problem. More complicated interventions that may be done in the hospital that you may kind of experience secondhand is, there are 2 things. One is stenting and one is a drug called IV-TPA, which stands for tissue plasminogen activator. Now, IV-TPA or streptokinase, that's also a drug that's really quite inexpensive, has been around 30 years and is available the world over, is an anti-clotting molecule. So similar to aspirin, it works a little differently, and it basically breaks up fibrin. So that sticky thread that we talked about earlier, it kind of inactivates it and causes it to go away. And that basically dissolves clots. So in a situation where someone has a heart attack, as demonstrated by an EKG and an appropriate history, you give them an aspirin, and within 30 to 60 minutes, you want to give them this IV-TPA. It reduces mortality further by about 30%. So even in resource-limited settings, where maybe there's a hospital, but you don't have a catheterization suite to do a coronary angiogram, which I'm going to talk about in a minute, you can still do an EKG, provide aspirin and IV-TPA or streptokinase, and you can have a marked improvement in that person's likelihood of surviving that heart attack. Now, an intervention that we've had really since the mid-90s that became more advanced kind of in the early 2000s are angiography with stent placement. And what that is they basically thread a catheter through the person's artery in their groin or in their wrist, and they thread a wire all the way up into the heart. They shoot a dye, and then they take a moving X-ray picture of the heart. You can see in the picture in the upper right that there's an arrow showing a narrowing of the artery, and that's what the cardiologist is looking for. If they find that, what they do is they thread the wire past that blockage and put a stent, which you can see between the patient's fingers in the lower left. They put a stent in that area, and then they use a balloon to deploy it or to kind of expand it. And what it basically does is it crushes that clot and that plaque against the wall of the artery and opens the blood flow. So that's kind of the advanced intervention that, you know, is kind of standard of care in the West. This generally should happen within 90 minutes. So again, you have some time, but you don't have a lot of time to provide sort of the appropriate intervention. Moving on to stroke, I want to talk about, again, like we did with a heart attack, how do you recognize a stroke? So there has been this idea of thinking about strokes like heart attacks, and they'll even call it, they call it a brain attack in some situations. And the idea is you kind of want people to get into this idea, into this frame of mind that the intervention with a stroke needs to be as quick as with a heart attack. And so we have a mnemonic called FAST. Doctors, as I pointed out, love mnemonics. It's how we remember all that information, which stands for face, arm, speech, and time. So strokes can show up in very different ways, but big strokes usually will cause some weakness on one side of the body. So the face droops, the arm is weak, the leg is weak. A lot of times people also have trouble with speech. Either their speech is garbled or they don't seem to be speaking properly. They can't find their words. They don't seem to understand you, and it's generally abrupt. So it's not something that develops gradually. It happens very suddenly. Sometimes people can become very dizzy or feel like the room is spinning. And they're also often very nauseated in that situation and sometimes sleepy. They generally don't lose consciousness, and they generally don't have what looks like a seizure, meaning they don't sort of shake uncontrollably. This act fast, which is sort of a mnemonic, is that any one of these criteria being present makes the likelihood of a stroke 72%. So they're actually pretty sensitive to kind of screening for people that need to get to a hospital setting quickly. So, I talked about earlier that when you have a heart attack, the problem is that there's a clot that's forming, and that's blocking the blood supply to the heart. In the brain, it's slightly more complicated. The most common kinds of stroke have the same underlying mechanism, where there's a clot that forms and it's blocking blood flow. That's about 85% of strokes. Now, some of the time there's a plaque that ruptures, like in a heart attack, and it causes a clot to form in that place. Sometimes people have clots that travel from elsewhere in the body to the brain where they cause a stroke. Either way, the treatment for both of those is similar. However, about 10 or 15% of strokes are hemorrhagic strokes or bleeding strokes, meaning that they're caused from an area of the blood vessel that breaks and causes bleeding into the brain. Now, you can imagine that these two are treated very differently, because if someone is bleeding and the blood is causing the problem, you want to stop the bleeding. Whereas if there's a blockage, you actually want to remove the clot or cause it to break up. So this is why, in strokes, you don't give aspirin just because you think someone might be having a stroke. Because in 15% of people, they're going to have a bleeding stroke, and giving them aspirin is going to make them more prone to bleeding, which is going to cause more of a problem. So stroke is a time frame where there is a time sensitivity we're going to talk about, but you really want to get them to a hospital setting. And when someone comes to a hospital, the first thing we do is a CAT scan of the head, or a CT scan. That stands for computed tomography. And basically what it is it's an X-ray, a moving X-ray. So the person lies on a gantry or a stretcher and moves through this donut or ring that has a continuous X-ray that rotates around them in a helix or in kind of a cylinder as the patient moves. And what it does is it creates this moving X-ray image that's then reconstructed and provides a three-dimensional picture that we classically look at in sections. So when you see a CAT scan or a CT, computed tomography of the brain, this is what it looks like. And what you're looking at is a cross-section of the brain sort of taken like this. Imagine you're standing at the patient's feet, looking up to the top of their head, and you're seeing a cross-section of their brain. That is what you're looking at. And on the left, you see a normal CT, which is what a normal brain looks like. Incidentally, it's also what a brain looks like that's having an early ischemic stroke or an early stroke from a blood clot forming. On the right, you see a hemorrhagic stroke or a stroke from bleeding. And you can see that the blood is this bright white that you can see in the middle of the brain where it shouldn't be. You can also see that the blood seems to be pushing the brain a little bit to the other side. In the case of a stroke from bleeding or a hemorrhagic stroke, the treatment that you provide is actually supportive. You want to make sure the blood pressure is lower, because really high blood pressure, the bleeding will continue. But you don't give them aspirin or any of these clot busting drugs. It's mostly supportive care. In ischemic strokes, the treatment's a little different, and we'll talk about that. The other thing that you may note if you go to a hospital and someone's having a stroke is we do this thing called the NIH stroke scale, or National Institutes of Health. And this is a way, strokes are very complicated and they can manifest in a lot of different ways. And what we want to do is to kind of quantify how severe someone's stroke is. And so this has been translated into many languages. It's used throughout the world over. But because stroke can cause complex problems with language processing and understanding and speech and reading, we have this standardized way to assess that, that you can see in this picture. So what you'll have a patient do, sort of in the picture where there's this woman washing dishes, you have them explain what's going on and see if they kind of understand that the children are about to fall from the bench, that they're trying to steal cookies, and that the woman is letting the sink overflow. In the bottom, you want them to name these objects, which are common things in the United States. People would know what they are, like maybe a cactus people wouldn't know in some parts of the world, but this is where it was originally studied. In the middle section, you want them to repeat the words mama, tip top, 50-50, and then you have them read the you know how down to earth, I got home from work. When we score it, we give it a number based on sort of how well they did and looking at strength testing and sensory testing. And that number can tell you how severe the stroke is. And that's helpful because when we talk about the interventions that we provide, the severity of the stroke actually makes a difference because the risk and benefit calculus in strokes is a little more complicated than in heart attacks. And I'll give you an example of that in the next few slides. So again, just reminding you of this clotting cascade, that when we have this ischemic stroke, you have this clot that's formed from fibrin and platelets and red blood cells. And incidentally, we use the same kind of drug that we use in heart attack, just at a different dosing, the IV TPA or tissue plasminogen activator, which basically dissolves clots. So this kind of brings us to what I was talking about earlier about risk versus benefit in medicine. Now, giving IV TPA to someone with a stroke can have a benefit in terms of improving their likelihood of being independent in 3 months. That's kind of the outcome that they looked at when they studied it. And you get a 10% improvement if you give this drug in an appropriate time frame in an appropriate patient. And you have to treat 10 people to get one person to benefit. So that's kind of how we think about this. Has to be given within ideally 3 hours up to 4.5. Beyond that point, it doesn't seem to provide a benefit, and they have more risk of injury, mostly from bleeding in the brain, which you can imagine because it's a clot busting drug. When we give this drug, we're always kind of trying to balance risk and benefit, right? So, even though they might have an improvement in being independent in 3 months, there's also a 5% increased risk of symptomatic bleeding in the brain. And so there's this idea in medicine of informed consent, where when you're providing an intervention that might harm someone, you want them to understand as best as they can that they may benefit and they may be harmed from it. You provide a recommendation, but they need to understand those risks that are being undertaken. Some of you may ask, well, why don't we just, if someone seems like, they might do well, why don't we give it outside of that time frame? And it's because when we've looked at it in a population of people, it seems to cause more harm than good. And there's this important concept of do no harm in medicine as well, which is that a naturally occurring process that causes harm is preferable to you doing something that causes harm to someone. So, and I think that that's very specific to medicine. There's a lot of other situations or areas of study where people are like, well, let's just try it. And the reason that we're very kind of cautious about it is that we're dealing with human bodies and human lives. And so there's a little bit of a heightened sense of responsibility, I think, when you're trying to decide how to work and do something in someone's best interests. There are some other more complicated interventions that we sometimes do if someone's stroke is severe enough. And that's determined by that number on the NIH stroke scale that we talked about earlier. If someone has a severe enough stroke that seems to be causing a huge effect, then that's usually a surrogate for like a really big artery that's being blocked. You can see in this picture, this is just a schematic of the arteries of the brain, that the brain has for one, a complicated circulation, but there's also this ring that allows for some redundant circulation, meaning that even if one section is blocked, that blood can kind of flow via these collaterals. This is sort of looking at a picture of the brain in an angiogram, which is a CAT scan where they shoot dye through the artery and then kind of reconstruct it three-dimensionally. And you can see that it's really quite tortuous. It sort of bends this way and that. When someone has a stroke, there's this idea of a penumbra, which is that when that blockage occurs, there's initially a very tiny area of brain that's dead that you can't salvage. But there's this larger area called a penumbra that's not quite getting enough blood and will die if you don't do something, but it's not dead yet. And this is sort of the rationale behind TPA and some of these other interventions, is that what you're trying to do is save that penumbra from dying by reestablishing blood flow to the brain. Some of these more complicated interventions, again, involve retrieving clots or direct injection of that IV TPA, that tissue plasminogen activator, into arteries that are blocked. This is not without risk, because the arteries of the brain are a lot more fragile than other parts of the body. But this just kind of gives you the sense of some of the science and some of the things that are possible. Subsequent care for all of these things involves antiplatelets agents like aspirin or clopidogrel, and then risk factor modifications. So similar to heart attacks, the underlying problem with both of these conditions is plaque formation in the brain caused by many years of diabetes, high blood pressure, high cholesterol, smoking. So in summary, I know I kind of went through a lot. We're going to go through some questions later. I just wanted a chance to kind of get through the talk. So thank you for being patient with me. But to recap, A, B, C, D, E, I don't expect you to remember all those things. It is easily Googleable, and it's pretty standard. But this idea that we use these mnemonics to kind of remember important things in stressful situations, part of that is it helps kind of cognitively unload us so that we can think better about other things. But also that, you know, when someone is sick, it can be very stressful. And to have that mnemonic helps you remember the things you should do. Stop the bleeding. If you see someone that's bleeding, the most important thing you can do is to try to help staunch that blood flow, because stopping it later does not have the same beneficial effect. We talked about chest compressions and CPR, which is complicated. And honestly, if you want to do it properly, you probably would need to take a course. But if you haven't and someone seems to have a stopped heart, doing just chest compressions is okay. It's better than nothing. And if you're in a place where you think there might be an AED, it's important to have someone go get it yourself and apply it, because really defibrillation in someone who has a heart attack, kind of shocking the heart to reset it, can be one of the things that sort of has the best likelihood of them getting better. And then heart disease and stroke are the number 1 and 2 causes of death in the vast majority of the world at this point. If you suspect a heart attack, it's okay to give full dose aspirin. You're not going to hurt someone. The intervention time window for severe heart attacks is 60 minutes. So you don't really want to sit on this. You want to sort of like mobilize your resources to get them to a place where they can treat a heart attack. And that the interventions in strokes, you don't give aspirin, because remember, some of them are caused by bleeding, but that there is also a time frame in intervention. So even in the US, we often see things where people will basically have symptoms of a stroke and go to bed and think that it'll get better in the morning. And unfortunately, at that point, it's too late. So I think I've finished here. I would like to take some questions now. And I think I will hand this over to Jane to kind of help mediate.
All righty. If you'll give me one moment, actually, I just want to take a quick second to put the attendance link in the chat. Sorry, just give me one quick second. There we are. Thank you, Shivangi. So yes, you can use the link in the chat to mark your attendance. You can also copy this link and save it for later. If you have some questions and you'd like to get to your questions and fill out the attendance later on, that is perfectly fine. Please remember to log into your Aspire account before filling out your attendance form. The form will close at 5 p.m. Eastern Standard Time today. All right. So now getting to some questions, I will be kind of just randomly calling on folks and asking them to unmute. So we will start. We will start with Sangupa. Sangupa Dennis, if you'd like to unmute and ask your question. Sangupa, are you able to unmute?
Yes, thank you so much, Professor, for this insightful discussion and presentation. My name is Dennis, and I'm here in Uganda. So this presentation was really good, but to me it was kind of far-fetched, because when you think about the kind of environment that we have here in Africa, whereby there are even health centers. Now, like in Uganda, we have health center 2s, 3s, 4s, general hospitals, and maybe regional referrals, and then national referrals. But you look at an instance where a mere health center 2, health center 3 doesn't even have oxygen. How are we going to be able to observe such things like maybe ABC? Of course, I know there are those things that you do not need oxygen for, but you know that now for my case, I'm a medical doctor. I recently finished my course this year in a Ugandan university here, but you find that there are these facilities that we are working in that don't have any of these. How best can we help these people, and how can Aspire come in to tackle some of these challenges? Thank you.
I think that's a great question. I think health is contextual. Certainly in Africa, as I sort of mentioned earlier, that sort of neonatal problems in the first year of life, and then lower respiratory infections, so like pneumonias in particular, are kind of the number 1 and 2 causes of death. So, this was an hour. I think your point is well made, and that I think the point that I'm just trying to make is that timeliness and systems matter. I think that for heart attacks in particular, aspirin's pretty universally available, even if other interventions can't be performed. But that might not, sort of in a local contextual situation, may not be the most important thing. So the topic was sort of chosen broadly, but I see your point that sort of in some parts of the world that may not be the priority, and some of it may be kind of resource limited and focused on other interventions. But even, to the point of like, neonatal, and this is sort of a specific thing, that even in like primary health centers in somewhere like in Uganda, that neonatal asphyxia, so lack of breathing kind of in the first few minutes of life, is something that can be often fixed by sort of simple bulbs to suction the airway, and then a bag to provide rescue breathing to kind of stimulate the infant, even in the absence of oxygen. So there are some very simple non-technological tools and interventions that have been shown to have like huge improvements in mortality, that don't necessarily require like huge amounts of infrastructure or cost or technology. A good question and an important point.
Thank you so much. Let's try. Sorry, just want to make sure we have different folks here. Let's see, Abida Farzana, if you'd like to unmute and ask a question.
Hello. Actually, I'm not from medical background, but I wanted to ask a question. If the aspirin is given on a high amount, then what will happen to that patient? If anyone is unknowingly giving high amount, actually the person who is giving the primary treatment, we don't know how much amount to give, then what will happen? And as you know, there are some side effects of aspirin, and I want to ask about that actually, and what will happen?
Well, I mean, the dose of aspirin you're giving is not high. So when we used to use aspirin to treat pain before we had safer medications for pain, people used to take, 2 aspirin every 6 hours. So this is a single aspirin pill once. So it's not a huge amount. The side effect is that it will make you more likely to bleed. The person is generally you're not going to give an aspirin to someone who's unconscious. So it's more in someone who's awake. You would ask if they have an allergy to it. But there's not really a lot of downside, which brings kind of the point of like risk versus benefit is like, if it really sounds like a heart attack, there's not a lot of downside to giving a single dose of aspirin, and you have potentially a 50% improvement in mortality if they're having the most severe kind of heart attack. I hope that answers the question.
Okay, let's try, let's see. I see Roshan Kumar. If you'd like to unmute and ask your question.
Yeah, thank you very much. Thank you, Michael, for a beautiful session. It was very much informative. So being a biological student, I have actually been a part of a first aid medical school. So where we taught about a lot of things, and I could relate it like whatever you are teaching. And in India, there are certain cases like where I feel like, when a person is going through cardiac arrest, we are not available, the aspirin is not available at that moment. Like we lack somewhere. So in those cases, what is the alternate we can use, or what we can do in such cases for cardiac arrests or maybe strokes?
Well, I think, if someone, and maybe I didn't, if someone's having a heart attack, you have to be able to kind of talk to them to know what's going on. If someone's heart is stopped and they're unconscious, then you have to have their heart start pumping again. So like in terms of order of priorities, if someone's in cardiac arrest, you have to get their heart pumping again before you administer any medicine like aspirin. There is rectal aspirin that can be given if someone's unconscious and you resuscitate them. But that's a situation where in terms of order of priorities, you're going to need to get, you're going to have to get a blood pressure and have to have the heart pump again in order to sort of like even get to that step where you're going to give them aspirin. Because if you can't bring them back, then they're dead, and then they don't, they're not going to need aspirin.
Okay, so like in that case, CPR will be useful for them, or it will be dangerous for them?
No, CPR is useful, right? Because if their heart's not beating and they're essentially dead. So if you can bring them back to life by performing CPR, by performing rescue breaths, by defibrillating, then if you have brought them back to life, then there are other interventions that you would do subsequently. But if someone is dead, you can't harm a dead person. So again, that kind of gets back to the risk versus benefit kind of calculation.
Okay, because you mentioned like if we are providing aspirin in case of a blood stroke or maybe some hemorrhages there, so it might lead to severe, disadvantages of it. Like if there is any blood clot or hemorrhage, something.
Well, so a blood clot and a hemorrhage are two opposite things, right? So okay. The point was in heart attack, the mechanism is that there's a clot that's formed that needs to be broken up. So it's a little simpler. In the brain, you can have very similar symptoms caused by either clotting or bleeding. You can't really distinguish them by talking or examining to someone. But the two kind of sections that we're talking about, ABCs is really kind of undifferentiated, very sick person who maybe cannot give you any information. 80% of medicine, of medical diagnostics is story, right? So when we talk about heart attack and stroke, that's in someone who's not so sick that they're unconscious and they're able to kind of talk to you and tell you what's going on. So they were kind of like two kind of separate kind of patient populations, if you will. So I'm sorry, I've tried to demystify that a little bit. So it would depend.
All right, Roshan, thank you so much for your question. What we'll do, we'll also start taking 2 questions at a time, just so more folks can get a bit interactive. So what we'll do, I will call on 2 folks. The first person, you can unmute and then ask your question. I'll then call on a second person who will also unmute and ask their question. And after you guys ask your question, again, we ask for you to limit it to 1 question. Then Professor Vortmann, he can answer those questions for you guys. All right. So I'm going to ask Wanani, if you could unmute and ask your 1 question.
Hi, okay. I'd like to ask that as a non-medical student, we are often advised to not move patients who have like broken bones or possibly their mobility has been affected. So in a case where I'm assessing the scene to see if it's safe for me and the patient who I'm trying to give emergency assistance to, say that the scene is unsafe, do I proceed to check if they are breathing, to check if their airway is blocked, or do I just like run if the scene is unsafe? What do I do since I cannot move this particular patient because I am not medically equipped to deal with the broken bones and whatnot?
Okay. Thank you so much for your question. And Kelvin, Kelvin Abugi, you can unmute and also ask your question.
All right. Thank you very much, Mr. Michael, for your lecture. My question is, when going for diagnosis for ischemic heart disease, what happens to the ECG? Because we've had situations whereby the ECG is normal and doctors still diagnose ischemic heart disease for such patients. So is that possible?
Thank you so much.
All right, so is it 2 questions or 3 questions? Sorry.
Questions.
One more time.
Sorry, 2 questions.
Okay, all right. All right, so first question was about sort of if someone is injured and seems to have broken bones and the scene is unsafe, like, what would you do in that situation? And I would say, first thing is if the scene is unsafe, then either you don't help or you make the scene safe, and sometimes you can't do that, or you move someone somewhere where it's safe. But if you're not sort of the trained person and there's trained people, then maybe you don't do anything. The most important thing is to not make yourself a victim or an injured person in that situation, right? Because then there's one more sick person. As far as if someone had a broken bone, if you ask that kind of ABC question, like, hey, what happened? Are you okay? And they say, oh, I'm in so much pain. I think this thing fell on my leg and my leg is broken. Their ABCs are okay because they're able to look at you, talk to you, tell you what happened. The key thing that would be an issue with a broken bone is if the bone were sticking out and they were bleeding a lot, would be control of the bleeding. That's really the only thing you can do in that situation. You're not there to like reset the bone or do anything like that. Now, in these kind of like situations like the Rana Plaza, which is the picture I showed, there are other things I didn't talk about there's something called start triage, which when you have a ton of people that are injured, how do you kind of determine who's sicker and who's not? And that's sort of a separate topic of discussion. But one easy thing that you can do if the scene is safe is you say, everyone who needs help, come over here, go stand under that tree. All the people who are able to walk, who can understand you, who can breathe well enough to do that will walk over. Those are the people who are less injured. The people who are remaining lying on the ground, those are the people who are sicker who need to be seen first. So that's kind of a general rule, but it wasn't something I talked about, but that's a good question. And then the second question someone asked, who sounded medical, was that sometimes the ECG will be normal and they'll still be diagnosed with ischemic heart disease, and is that possible? And the answer is yes, it is possible. There's a whole spectrum of kind of heart disease. And so heart attack and a complete blockage of the artery is the most severe kind, but there are other less severe kinds. There's that where there's a partial blockage of the heart, where you might not have ECG changes because everyone's ECG is a little different. One way we help distinguish is something called troponin, which is a blood test that is a heart protein that only leaks into the bloodstream and is detectable if the heart has been injured. But a lot of times you can have a negative troponin, and it kind of depends on the person's story, again, because diagnosis in medicine is sort of 80% story or history. And so if someone's saying like, well, I get this sort of chest pressure, it feels like a squeezing every time I go walk upstairs, and I get a little sweaty, and then I rest for like 5 minutes and it gradually goes away, that sounds like ischemic heart disease or angina, which is pain from the heart. But the most severe kinds of heart attacks should cause a classic ECG change. So good question. Again, it kind of gets into some of the nuance of medicine.
Great. And I did have a question here. Sorry, I'm just trying to find it. Okay, I can't exactly find the question in the chat. So we'll call on two more folks to ask questions. The first person I will ask is Ahmad Kher. So Ahmad, if you could unmute, please feel free to ask your question.
Yeah, hello. Thank you for the opportunity, and it was a very interesting seminar so far. So my question was, like, at what point should the aspirin be delivered? Because, like, when delivering it to the patient, it will take a while before it takes effect and it's a pill. So, what is the case with that? When should it be delivered? And is there like an intravenous version of the aspirin or the IVTPA that would be introduced to the patient?
Okay, thank you so much for your question, Ahmad. And we will also ask Katerina Cote, if you'd like to unmute and ask your question as well.
Yes, thank you. So my question is, and my question comes from not only what you said in your presentation, but also from a personal experience. You said that sometimes patients who might be having a heart attack don't have actually chest pain, so not the regular maybe symptoms. And this happened with my mother a few years ago. She did not have chest pain, but very extreme abdominal pain. And I have read that for women, the symptoms are not the same as for men. So what are some other symptoms that may not be the normal or the ones we know for heart attacks? Thank you.
All right. So the first question was when to give aspirin and when, if there's an IV formulation there. I'm not aware of an IV formulation of aspirin. It's either chewed or you give it rectally if the person through the rectum, like as a suppository, if the patient's unconscious or can't swallow. When you would give it, I think, if you can get them to the hospital quickly and they can see them promptly, then you could probably wait. If it's going to be a delay, if they have an exertional symptom and it's chest pain, and it seems like it's worse with doing something, then it's not unreasonable to give it sort of after you've talked to them and sort of heard what's going on. As far as the person whose mother had a heart attack, I'm sorry to hear that. I hope she's okay. Yeah, women and older people and people with diabetes too, don't often have or often do not have classic symptoms of chest pain. So some of those things will be, like in your mother's case, abdominal pain. Usually it's upper abdomen, so because the heart sort of sits right on top of the abdomen, or nausea, or extreme fatigue, or shortness of breath, or sweating, or dizziness. But it's something that happens generally abruptly, and it's worse with exertion. So even if you're not having classic chest pain, the symptoms should be worse with walking. If it's really unclear because it's a very atypical story, then sometimes that's none of these things I'm saying are like 100% in all people. And so sometimes if the situation's not clear, they just have to see a doctor, or see someone who knows something, who would maybe do some testing. Because even to me, who's been doing this a while, a lot of times it's hard to figure out only from the story without doing some objective testing, because people experience things differently and relate their stories differently.
Wonderful. I do have a question here from the chat from Sabrina Mansour. And her question is, what are the common symptoms of heart block or heart plaque? And if someone has pain from the left neck of their fingertip, is it a sign of a heart disease, or what are some additional signs that we can look for?
I mean, heart problems generally are exertional, meaning like emotional distress or activity makes it worse. And as far as like she mentioned, sort of like fingertip, sometimes there's a concept in medicine that internal organs don't have the same nerve supply as, say, your arm or your face or your hand. So if someone like touches me, I know like, oh, you're touching me on the tip of my second finger. But your organs in your body don't have that same specific nerve wiring. And so the heart, when you're having a problem with your heart, sometimes you feel it in your chest, but sometimes you feel it in your upper abdomen because it's kind of adjacent to that area. And the heart, you're not always able to localize where your discomfort or pain is coming from just because of the way that we're built. Sometimes people feel it in their neck on the left side, and sometimes they feel it in their shoulder and upper arm. They generally don't feel it all the way in their fingertips. That's a little uncommon, but like a squeezing in the upper arm is not an uncommon thing to feel, but it's always left-sided.
Sorry, I was on mute that whole time. My apologies. Ali Mami, if you'd like to unmute and ask your question, please feel free.
Thank you very much for the opportunity. How can someone with no medical experience or background know if a person is having a heart attack, and what should this person do in such a situation?
Well, I think, again, people who are having heart attacks generally look sick, like they don't look well. And they, I think that the point of this lecture was to kind of empower you with a little bit of information and kind of give you a sense of how doctors will think about something. I don't think from an hour lecture is not medical school, right? So a lot of times there's some nuance and some complexity. I think the ABC bit is kind of like in an extreme situation where someone is going to die imminently or dead already. Like, what are things you can do? Because they really, if you wait for whatever system to bring in the hospital, they'll be dead and it won't really matter, right? And I wanted to give you a sense of kind of what leading causes of death were and sort of demystify the sorts of treatments that are available in our modern world. But I don't think, I'm not expecting you to be able to be an advanced diagnostician just from, talking to someone having no medical training. I think the point is that if someone looks sick, or if they feel sick, if it's an acute or an abrupt onset of illness, and if they have any of these things that are sort of like, chest pain, nausea, dizziness, arm pain that's worse with doing exertion or doing activity, that's something that should raise your suspicion and make you want to think about how to get them to a level of care where it can be figured out. I realized in a lot of places around the world, it's not so easy that you pick up the phone and call 911. Sometimes you have to travel quite a ways and you have to decide, is this a primary health center problem? Is this sort of a referral health center? Is this tertiary care? That kind of thing. And so it's more about, I want you to think about the problem and realize that some of these problems are timely, meaning that you can't just sit on it and hope that it gets better.
Thank you very much.
All right. Thank you so much for all of your questions. We really appreciate the engagement. And again, we enjoy the fact that so many of you are enjoying the session. Thank you so much again to Professor Michael Vortmann for joining us today and giving us this very informative seminar. In all honesty, I used to take first aid classes once a year, and I stopped for a while. So this actually has me kind of a little motivated to kind of go back to taking first aid and CPR classes, just to make sure that, in case there's an emergency, it can somewhat help. So again, we have shared the attendance form in the chat. Please feel free to fill that out before the end of the day. If you would need to copy the link and save it to fill it out later, that is perfectly fine. Please feel free. Thank you so much again, Professor Vortmann, for joining us today, and we hope to see you all again soon.
All right. Thank you all for listening. Appreciate the opportunity.